Good afternoon, everybody. Welcome to the first CME session for 2026. I welcome you all on behalf of CSRRSL. Today we have two talks lined up. First one will be done by Dr. Amanda Embuldeniya, Decoding Neuropsychiatric SLE, Lessons from the Ward. Dr. Amanda Embuldeniya is the consultant rheumatologist, consultant in rheumatology and rehab in Teaching Hospital, Polonnaruwa. Over to you, Amanda.
Thank you, madam, and good afternoon to you all. I'd like to start by wishing you all a very happy new year. So I'm going to talk to you about neuropsychiatric SLE, or we call it NPSLE, which is one of the most fearsome manifestations of lupus. And I like to call it lessons from the ward, as I will be telling you stories about some patients we have seen during the last year. So this is a quick outline of my presentation. We'll be looking at what NPSLE is and what causes it, how would patients present with it, and we'll be looking at some case notes and how to treat it and how to implement the lessons we've learned in real life scenarios. So a neuropsychiatric SLE or NPSLE refers to neurological and psychiatric manifestations which are either caused by or directly related to SLE. So it may be happening in your central nervous system, peripheral nervous system, or your autonomic nervous system. So most of the time, in most cases, these neuropsychiatric problems happen around the time of diagnosis or during the first year of the diagnosis, but it can happen at any time of the disease course. This is one of the major contributor to mortality, so identification of these cases at an early stage is extremely important, and people who survive the disease may end up with significant morbidity and reduced quality of life. And about the prevalence, so if you look at the literature, the prevalence numbers are widely varying in a very wide range because the definitions they have used in researchers and the methodology they have used are quite different because the case numbers are not very high. But what we know for a fact is that this is extremely common in females who are mostly in the childbearing age, and also it is more common in Asian population when compared to Caucasian populations. The fortunate thing is the less severe symptoms, such as the things which will need only symptomatic management, are more common. As example, headache, mood disorders or psychosis are more common comparatively compared to more sinister causes such as demyelinating or inflammatory or cerebrovascular diseases. So many years ago, in 1999, American College of Rheumatology published a classification system to better understand neuropsychiatric SLE, and over the years this has been revised by many authors. However, the core of the classification system remains the same. So they describe 12 central nervous system syndromes and 7 peripheral nervous system syndromes. So among the central nervous system syndromes, you have much more sinister problems such as aseptic meningitis, demyelinating problems, and cerebrovascular disease, and also you have more symptomatic problems such as mood disorders, anxiety disorders, and psychosis. In your peripheral nervous system manifestations list, you have neuropathies, demyelinating problems, cranial nerve problems, as well as myasthenia gravis. So the precise pathogenic mechanisms of NPSLE is not well understood even in the present day, but from the available literature, we know that there are different mechanisms involved. Even in one patient who has just one symptomatic manifestation, there are multiple different immunological mechanisms activated in the brain. So we know that there is immune-mediated damage, autoantibody-mediated damage, then inflammatory cytokine deposition, which is causing further damage in the nervous system. And for some reason, there is breakage or disruption of the blood-brain barrier. We don't know the exact mechanism what's causing it. However, when this happens, all these inflammatory products are permeable and then causing permanent damage. What we have better understood is antiphospholipid antibodies, which is damaging the nervous system with thromboembolic disease. So, because the pathogenic mechanisms are not very clear to us even today, we don't have a gold standard serological investigation or an imaging modality to confirm your diagnosis for sure. However, we have identified a few antibodies which might be related or which you might use to prognosticate your patients. So one is anti-ribosomal P antibody, which seems to be related to lupus psychosis, and then NMD receptor antibodies, which are associated with cognitive problems and seizures, and obviously antiphospholipid antibodies, which may be related to thromboembolic disease. So when you are looking at your patient and trying to identify whether this is a neuropsychiatric SLE or something else, you have to think about unrelated problems which might be quite common in these patients. So among these unrelated but very serious problems, the first thing you have to think about is infections, because these patients are immunosuppressed by the disease itself as well as from the medication. So infections are quite common. Also, there may be metabolic disturbances such as uremic encephalopathy in a patient who might have lupus nephritis, or endocrine problems such as autoimmune endocrinopathies, which are also associated with autoimmune problems. Also drug adverse reactions, which are quite common. So you have to think about all these things. So among the drug adverse reactions, you have to think about the medications you are already using on these patients. So azathioprine is reported to cause headache and aseptic meningitis. Various antibiotics like cotrimoxazole, which can cause aseptic meningitis, and other anti-seizure medications and neuropathic pain medications. You have to exclude these causes before you think about or confirming the diagnosis of NPSLE. So this is a more clinical approach when you're trying to diagnose your patients. So it's easier if you think about the causes in a more systematic manner. So you have your NPSLE in your central and peripheral nervous system, and then you have disease complications and associated diseases. So in the central nervous system manifestations, you can clearly differentiate your vascular problems, seizures, inflammatory and demyelinating problems. Then you have things which is causing altered mental status such as confusion, delirium and psychosis. You can always categorize the less sinister things such as headache, mood problems, anxiety and fatigue, as these things usually require only symptomatic management. So now we will be looking at clinical syndromes in a more clinical manner. One by one, we'll look at vascular presentations first. So this is our first patient we had earlier March last year. So this was a 19-year-old girl who was previously healthy. She presented to the hospital with a facial and upper chest rash, and dermatology team diagnosed her to have DLE with a skin biopsy. Further investigations revealed a moderately elevated ESR with a positive ANA. She also had significant thrombocytopenia and anemia, but she did not have APLS features. Her APTT was normal. So she was put on HCQ and azathioprine and a tapering dose of prednisolone, particularly because the platelet counts were quite low, and DNA and APLS screening was not done as these things were not available. So 2 weeks later, she presented to her routine follow-up in the clinic. She felt much better, rash was almost disappearing, and platelet counts were above 150. So HCQ, azathioprine were continued and steroids were tapered further. And 1 week from this clinic appointment, she was brought to the ETU by her parents, unconscious, and she was intubated on admission. An urgent non-contrast CT brain revealed a large brainstem infarction with hemorrhagic transvasion with significant cerebral edema causing obstructive hydrocephalus. Unfortunately, EEG showed flat lines and she was declared brain dead. So cerebrovascular disease in SLE can present as ischemic strokes, TIAs or hemorrhagic strokes. However, hemorrhagic presentations are quite less common. There is a strong association with APL antibodies. However, you have to always think about traditional risk factors such as hypercholesterolemia, uncontrolled hypertension, as they may also be present in these patients who are on steroids and who might have other comorbidities like renal problems. So all stroke subtypes can occur in SLE, and highest risk is seen in patients who are less than 50 years of age. So there are different mechanisms how the strokes are happening in patients with SLE. The commonest one would be APLS antibodies causing thromboembolic events. Again, people who have lupus myocarditis with arrhythmias and shooting emboli can have strokes. Again, you have your traditional risk factors and also vasculopathies, CNS vasculitis, which seems to be very rare in the literature, and also TTP and TMA. So when you look at our patient and what happened to her, you might have the question whether we could prevent this, we could have prevented this stroke. So about primary prevention of strokes in lupus patients, particularly even they have positive antiphospholipid antibodies, this is not recommended in the guidelines, and there is no strong evidence. However, when you go through the case notes, you might consider on a case-by-case basis. If somebody is having significantly high APL antibody titers, you might consider adding aspirin. However, this is off-label. There is no guideline recommendation for this yet. And at the same time, you should not forget your traditional risk factors, and they should be managed accordingly. So moving on to further clinical syndromes, now we are looking at inflammatory, demyelinating as well as cognitive problems. So this is our second patient whom we have encountered about 6 months ago. This was a 27-year-old female, a mother of 2, a known patient with SLE for about 1.5 years. Her first presentation was with lupus nephritis, inferior STEMI with a large coronary aneurysm, hematological manifestations and mononeuritis multiplex. She declined renal biopsy at the time, and she was put on warfarin and started on a course of 2 weekly cyclophosphamide. However, in the middle of the treatment course, she was defaulted and she did not attend her clinics. So later on, she presented with slurred speech, loss of balance, tendency to fall. She also reported a few days history of headache, fever, vomiting, blurred vision and diplopia. There was no clinical evidence of lupus in other systems, but she had complex ophthalmoplegia, cerebellar signs without any limb weakness. Basic investigations revealed thrombocytopenia, significant proteinuria, and her complements were low. And during the course of the hospital admission, she had a renal biopsy which revealed class 2 nephritis. With regard to her presenting symptoms, she had a contrast CT brain and a venogram and orbits. There was cerebral edema present but nothing else. EEG showed diffuse theta slowing suggestive of encephalopathy. Lumbar puncture revealed very high proteins with only a few cells. So she was managed as thromboencephalitis related to lupus, and she received high-dose steroids with cyclophosphamide, following which she made a complete neurological recovery. So cognitive dysfunction is one of the under-recognized manifestations of NPSLE. These patients can have memory impairment, executive function problems, and attention issues. The presentation could be subtle but progressive, and eventually patient will end up with significant impact on their daily functioning. So there are various inflammatory manifestations of NPSLE which you might be aware of, like encephalitis, cerebritis and myelitis, and also there are demyelinating problems which could mimic multiple sclerosis. So these patients could present with different clinical symptoms such as seizures, focal neurological deficits and cognitive dysfunction. So moving on to the third syndrome, this is our third patient who was a 23-year-old female with diagnosed SLE. She had been in remission for several years. Therefore, she decided to stop all the medication by herself as she had some plans of conception. She presented to us for the first time with a low degree called autoimmune hemolytic anemia. She also had thrombocytopenia. After taking hematological opinion, she was started on azathioprine and prednisolone. Initially, she showed a good enough response. However, gradually her disease activity went up and we had to admit her for IV steroids, and we decided combinedly with hematology team to start her on rituximab. So after the first rituximab dose, she left the hospital again, medical advice, and 48 hours later, she was brought to the ETU with status epilepticus. She has had prolonged seizures at home, unfortunately. She did not survive despite steroids, cyclophosphamide and plasma exchange. So seizure disorders is one of the most common manifestations of NPSLE. Commonly, they present with generalized seizures, but focal seizures can happen as well. This is commonly associated with active systemic disease, but it can be the sole manifestations of lupus activity as well. So there are different risk factors. However, it is very important that you do not presume SLE to be the sole cause of the seizure. You should always investigate a new onset seizure similar to any new onset seizure in a non-lupus patient. So once you have exhausted all the alternative explanations, in a patient who has refractory seizures, you could consider immunosuppressive therapy. So less common manifestations, acute confusional state and psychiatric manifestations. So acute confusional state could present as attention problems, cognitive impairment or delirium, usually associated with very high disease activity. Again, important to exclude infections and other causes. Sometimes patients could present with hallucinations and delusions, and depression is quite common, particularly in these patients who have stress due to chronic debilitating illness. However, there are instances the depression is organic, so you have to treat it with disease modifying agents. Again, anxiety is quite common and sort of easier to treat when compared to some of the sinister manifestations, and very important symptoms would be steroid-induced psychosis or other psychiatric manifestations, so that is something to bear in mind. Again, further less common problems, myelopathy and movement disorders. These are quite common, quite rare, but reported in the literature, and usually associated with poor prognosis, so patient will benefit from early suspicion. So moving on to the next case, so that is peripheral nervous system manifestation. This is our fourth patient who we had very recently, a 41-year-old mother who was transferred from a local hospital with general ill health, joint pains and hair loss. When inquiring, she reported having 3 first trimester miscarriages in the past. She also had a history of ischemic heart disease, dilated cardiomyopathy. However, this has not been extensively investigated. She was on warfarin. During this presentation, she had subnephrotic proteinuria without any active sediments, normal creatinine, severe thrombocytopenia, moderately raised ESR and CRP. So she was suspected to have lupus, therefore we asked for ANA, which was very strongly positive. Again, DNA and APLS was not done as these things were not available, but we managed to get a very early renal biopsy which showed class 4 lupus nephritis. So while these investigations were done, she was put on high-dose steroids. While receiving steroids, she complained of heaviness in the right leg. But there was no demonstrable weakness, sensation was normal, so the treating team suspected functional problems. However, the complaints were ongoing, and the treating medical team did an NCCT brain to exclude stroke. It was completely normal. However, 24 hours later, there was demonstrable flaccid weakness in the right leg. Eventually, within a day, the weakness was progressive to the left leg. Therefore, she had a nerve conduction study which revealed asymmetrical A-man type Guillain-Barré syndrome. So a neurology team was involved at this point. So her treatment was escalated from steroids to cyclophosphamide to cover both renal and other manifestations, as well as IV immunoglobulin, which was specific to her neurological manifestation. Patient required some rehabilitation with orthosis. However, after a few weeks, she made 100% recovery. So peripheral system manifestations in NPSLE could be peripheral neuropathies, mononeuropathies or mononeuritis multiplex, cranial nerve involvement, autoimmune problems, AIDP sort of manifestations, as well as myasthenia gravis. So some of these manifestations could be treated as general lupus activity. However, certain manifestations, as in our patient, would require a specific neurological management. So it is always important you get involvement of other relevant subspecialties. So moving on to the last clinical case. So these are the most symptomatic problems: headaches, depressions, anxiety and fatigue. So this patient was a 44-year-old female who was previously healthy, who presented to us in January last year. She reported intractable headaches, which was initially treated in the OPD without good enough response to simple analgesics. She had a NCCT brain, which was completely normal. Basic investigations again was completely normal. During further inquiry, she had reported some hair loss, some photosensitivity. Therefore, she had a ANA which was positive, and it was in the nuclear homogeneous pattern. So she was suspect to have SLE with or without antiphospholipid syndrome, so she was put on HCQ. As the symptoms were ongoing, she eventually had a MRI brain, which showed multiple stenotic segments in the superior sagittal sinus, and it was reported that this could be due to chronic venous thrombosis. However, there was no evidence of venous thrombosis at the time of the study. Eventually, she had a CSF analysis which showed markedly raised CSF protein levels. And further examination, history and examination did not reveal any lupus involvement in other systems. Her DNA was negative despite of positive ANA, and complements were completely normal. She also managed to get an antiphospholipid screening done in private sector. That was again normal. Eventually, after further investigation, she was found to have TB meningitis, and despite of treatment, patient unfortunately succumbed to the illness. So headache in SLE is common but quite controversial topic. So these headaches could be migrainous or sometimes short-lasting. It is always important to exclude secondary causes if you take our patient as an example. So when you try to define lupus headaches, there are different classification systems trying to make it more easier for the treating physicians. But basically, when you look at these things, you could call it a new onset, severe, persistent headache which is not responding to narcotic analgesics, and it could be migrainous in nature. So when you look at all these NPSLE manifestations, I think you would agree with me that diagnosing NPSLE is quite challenging to a rheumatologist or any other person who's encountering this patient for the first time. There is no single diagnostic test for NPSLE, and basically it's a diagnosis of exclusion. And most of the instances, these are multifactorial in etiology, so you have to have a wide array of investigations to exclude certain things and to confirm certain things. It also doesn't make your life much easier that the investigations are not really available in our settings. So sometimes it's quite difficult to get antibodies done, to arrange an MRI scan, and SPECT scans are extremely difficult. And some investigations which are freely available in our settings could be misleading as well. As an example, you might think of infections and delay your immunosuppression if the procalcitonin levels are high. And now we have procalcitonin available in most of the hospital. But unfortunately, this does not have a very good positive predictive value, and procalcitonin is elevated in most of the systemic inflammatory conditions. So you could use other available investigations such as lumbar puncture, EEG, nerve conduction studies, and CT or MRI to confirm or aid your diagnosis. So according to literature, MRI with diffusion weighted images seems to be the most sensitive test. If available, you can use other advanced imaging modalities as well. Unfortunately, EEG and CSF analysis is quite vague, non-specific in lupus NPSLE, but you can use these things to exclude infections when you're thinking about intense immunosuppression. So again, autoantibody testing, which is very helpful if you can get your hands on it, but unfortunately not freely available in our settings. You can use specific antibodies, which I was talking about earlier, to prognosticate your patients. Antiphospholipid antibodies are quite helpful if it is a thromboembolic manifestation. You can always use ANA and DNAs or complements to take a look at the general lupus activity, which is usually elevated in these patients. Brain biopsies are rarely needed and very rarely performed, only in very specific centers. It is used when it is used to sort of exclude sinister causes and when the diagnosis is uncertain. So just a few tips about management of NPSLE. Again, there is no standard recommendations of NPSLE management. We have a guideline from 2010 which has not been updated since. However, the treatment seems to be more sort of a empirical management. So it is important and helpful if you can differentiate whether this presentation is inflammatory or thrombotic, then you can treat accordingly. And always you have to treat the comorbidities if you feel like these are causing the symptoms. And I can't emphasize enough the importance of multidisciplinary approach, because most of the time these things are involving at least 2 organ systems. Immune suppressive therapy, you basically start with high dose steroids, then eventually escalate it into oral DMARDs. If needed, in severe cases, you can try cyclophosphamide and B-cell depletion as well. Antithrombotic therapy is used in patients who have thromboembotic problems, and the important thing is secondary stroke prevention in patients who might have risk factors. So prognosis and outcomes. Prognosis is unfortunately generally bad when it comes to NPSLE cases, and it varies highly in these patients according to the system which is involved in that particular admission. It is very important that you have a very high degree of suspicion and recognize them early, but even despite of treatment, most of the patients end up with residual deficits, which might need long-term rehabilitation. So this brings to the end of my talk, and at the end of this 30 minutes, these are the key messages I want you to take home with you. First thing is, NPSLE is a quite complex clinical spectrum. It has 1,000 phases, so you have to have high index of suspicion in order to pick up the cases and treat them accordingly. Most of the time, you have to depend on your clinical sensors, as there is no gold standard test, and most of the time, diagnosis is by exclusion. And the key thing is treating early and treating aggressively, which will minimize neurological deficits. And always remember to exclude infections and secondary causes before you think about confirming your diagnosis. Again, MRI may be normal and misleading, so always trust your clinical instincts and don't forget your supportive management. So that brings to the end of my talk, and I'd like to thank my patients and all other stakeholders in managing these complex patients, and I'd like to thank the rheumatology team at Teaching Hospital Batticaloa for helping with the case notes, and these are my references. Thank you.
Neuropsychiatry SLE. It's one of those things, biggest challenges in a rheumatologist's life to diagnose NPSLE. As she pointed out, even MRI can be, normal MRI cannot diagnose or exclude. So it's time for questions, comments.
I have one question, Amanda. In that third case, I think the patient who went against medical advice after rituximab, who came with status epilepticus, did you think of possibility of PML after rituximab as well? And if so, what is the timeline usually you get it after giving rituximab? I just want to...
Madam, actually, I just used that patient just to say that seizures could happen at different times of the disease course. But this particular patient, very interesting case, she presented with a very severe cold IHA, which was sort of difficult to manage. So we decided to go on a weekly rituximab regime according to hematology. But while she was receiving this, she started developing renal manifestations. So her urine protein was gradually increasing. So we was thinking about evolving lupus nephritis. So when she was brought to the ETU with status, actually she had a massive AKI, and it was a very short period of time she succumbed, but we thought it's probably uremic encephalopathy at the end of it. But we believe that if she remained in the hospital and we had the time to do the biopsy and maybe put her on cyclophosphamide, the outcome would have differed, but we think it's probably uremia.
Thank you.